asymptomatic, and that's why it goes underdiagnosed unless you screen for it. That's why we need screening. The patient at high risk could be challenging to identify. For a population like primary biliary cirrhosis could be easier because the whole population is at risk, like, as we said, of osteoporosis, and the all has to be screened. But in the general public and general populations, it varies who you should screen and what age and when. Could be a more challenging issue. And there's a problem with management. So there's a problem of choosing the right medications, the complications that everybody, we're going to see that at the end, worry about with our treatment strategies. And the other one is adherence to the treatment, which is another problem because a lot of our drugs are once a week, sometimes once a month pill, and a lot of patients will forget to take them. So how do we diagnose? Now we are screening everybody at high risk. How do we screen them? The most common used test is a Dexa Scan or density test. It is a non-invasive test. It's just an X-ray based test where you sit on a table. It takes a few minutes to finish. There's no IV, no injections, nothing. And the exposure to the X-ray is very minimal with the Dexa Scan. Who should be tested in general? So all women above 65, that's the recommendation, so it should be tested. And men above 70, they tend to get it later than men. Now, if you have any fragility fracture or prior vertebral fracture or any hip fracture, of course, or any fracture that is not because of a major injury or trauma or accident, then you suspect you have osteoporosis and you test for anybody above 50. Postmenopausal women, now above 50, and if they are in the high risk category, now remember the high risk, smokers, alcohol consumption, strong family history, certain drugs. If you are in this high risk category, you start 15 years early screening for osteoporosis at 50. And this could include also primary biliary cholangitis. And if you have other medications on board, especially the steroids, that's when you start screening even for younger age than 50. So what is a Dexa scan? So how we look at it? So this is, as we said, an X-ray based test. It is done for more than one reason. One, it confirms your diagnosis. It gives you a diagnosis. Based on the number we're going to review now, it's going to tell you have osteopenia, you have osteoporosis, or you're in normal range. Plus, the numbers you have can predict how likely you are to have a fracture. And remember, our treatment is targeting fracture reduction. We're not treating numbers here, but that gives you an idea how high of a risk you are to have a fracture depending on how bad your numbers are. That's it. And very important here also for the Dexa scan is it's used to monitor progression or not of the disease and if you need to change something in your treatment or in your behavior. That's how it looks. I mean, different machines have different graphs. I'm going to give you a couple of examples from our machine at MD Anderson. But it will give you a T-score and a Z-score. Don't worry about all these numbers. I'll explain quickly. Perhaps all you have to remember is your T-score when you look at a Dexa scan, and that's what you should discuss with your physician, the T-score, because the definition by the NIH or even the World Health Organization depends on the T-score, and these scores goes in negative numbers. So a -1 and above, you're normal, and anything below a -1, if they give you a -1.6, 1.8, up to or down to -2.5, that's the osteopenia. And anything below a negative or -2.5 is osteoporosis. That's all you need to know for osteoporosis. The other numbers are for the machine and for us to worry about. And these are the World Health Organization classification of osteoporosis, exactly what you just said. So you look at the T-scores, and between a -1 and -2.5 is your osteopenia, and we call that low bone mass. And you call it the osteoporosis if you have a -2.5. And severe would be a -2.5 or lower with a fracture. And if you have a fracture with osteopenic numbers, if you have any of these fragility fractures and your numbers are not at 2.5 or lower, negative, you still are diagnosed with osteoporosis. So these are, again, numbers important to diagnose osteoporosis, but also to monitor osteoporosis. And they're not the only thing we go by to decide on treatment, and other risk factors, other medications, other health issues or comorbidity will go into play when we decide on treatment. So just having a negative 2.5 or a negative 1.5 does not buy you a treatment or get you straightforward to treatment. There are other things we consider too. So these are a couple of examples for you to get familiar. I mean, and those things I discuss with my patient. I show them their pictures, I show them their numbers, I try to go over it. Because that's a chronic disease, they're going to come back for years to come on treatment or off treatment. And again, as I said, I cannot see this well. You look at the T-scores, and you see this patient has, that's a negative 2.3, negative 2, negative 2.4. So that's to make a diagnosis. So once you see a number like negative 2.4, it's osteopenia, it's almost osteoporosis. What's also important, like we said, is to monitor, and that will be below the level of your diagnosis, is the prior years. Where were you before and what's happening? And that could be as important as the diagnosis itself, so how you're doing over time. So as you see here, we have numbers from 13, 14, and 15. Between 13 and 14, the patient was stable, and here you see a little drop, and the machine or the computer will calculate statistically if it's significant or not, and if you see a star next to a number here with a change, that means it's statistically significant. So this is the statistics. It's like the election, if you want. There's a margin of error. Until you cross that margin of error, you cannot call the race. So exactly like these two numbers, they're not the same, but we call it unchanged because you didn't get a star here. It's not statistically significant. Once it's significant, we call it a drop. And that can go in the decision to manage or not. Although this is osteopenia now, not at osteoporosis level, because we saw this drop, a significant bone loss, we know that this is the way it's going. So we don't have to really wait to your full-blown osteoporosis before we do something about it. So just looking at it without being at the diagnosis of osteoporosis, you can tell who's at high risk and who will eventually get there and try to prevent that. So that's the same patient, that's the spine density. The Dexa scan will measure your density in your lower spine and in your hips. And this is the same patient with the hip Dexa scan, and that's how it looks. Just to let you know, the osteoporotic fracture are usually happen in the neck of the femur. And these are the numbers here. Again, you look at the T-score. That's another example. I give you this to give you some what we deal with in clinic in and out. As you see, this is the spine Dexa scan. Almost completely normal numbers here. You see nothing even below negative 1.2. You tend to call it normal. I'll come back to this later. That's the hip of the same patient. And there are more or lower numbers, a negative 2, like full-blown osteopenia, going to osteoporosis number. And that's why you need to sit down with your physician and talk about why we have a normal spine, why we have abnormal hips. And one of the reasons could be other conditions you have, like osteoarthritis or bone spurs on your spine. Like this picture, you see how white it is here when on the x-rays. That reflects perhaps a degenerative disc disease and degenerative back disease causing bone spurring. So remember, this is an x-ray calculating how white it is to give you a score on your bone density. So if you have osteoarthritis, it does not make your bone stronger, except it causes bone spurs, and the computer will catch that at bone and gives you a falsely elevated numbers. So everything should go into calculation, and you should have those discussions with your doctor, because sometimes we have discrepancy in your numbers between your hips and your spine, and even while monitoring and following, you'll have some changes depending on what other conditions you have. So what else we use to try to quantify, if you want, the risks of osteoporosis, and more specifically the risk of osteoporotic fracture? So if you're in the osteopenia range, you're not a clear indication to start therapy. There are other methods to see who are at higher risk than others, other than taking a good history and have family history and social behaviors. There's a score we call a FRAC score we use. That's plugging in certain number. I'll show you an example about age, sex, height, weight, history of rheumatoid arthritis, steroid use, smoking or not. You put these numbers in the computer and it gives you a risk over 10 years of having a hip fracture or a major osteoporotic fracture. So now if that risk is above certain numbers, even if you're in the osteopenic range, also it could be an indication to treat. So it's a calculation method. And that's how it looks. It's an online tool we use. So you put the age, you have the weight, the height, if you have prior fractures, yes or no, family history of fractures, smoking, glucocorticoid, rheumatoid arthritis, other causes of osteoporosis, like we said, like hyperparathyroidism or hyperthyroidism or primary biliary cirrhosis or cholangitis. And then you plug in your numbers from your osteopenic numbers. Remember, this is osteopenia, and then it gives you these two numbers. And this is, so here you see the hip fractures score is 4.9, the major osteoporotic 1.17. The magic number, if you want here, for the hips is 3, for everything else is 20. When you cross those two, even if you are still osteopenic, that could be an indication to treat, to start pharmacotherapy. As you notice here, also, they do not account for all risk factors for osteoporosis, including in our cancer population. So that's only one of the tools we use, but our patients for certain cancer at higher risk, they're not here in this table. So it gets more complex. So just getting the discussion with your physician going about your risk factors, your history, your family history, your social habits, and the FRAX score, plus we put all together to come up with a plan or strategic plan to treat for the future. So why we treat? What's the goal of therapy? Again, is reduction of fracture risk. That's the goal. It's not the numbers. It's the goal. Actually, there are some studies saying if you are on treatment, even those numbers don't change, you are at low risk of breaking something. We like to see them getting better, but it doesn't have to be. So you need, one, prevent fractures. You need to improve mortality and functional status. That's big, as we said. Osteoporotic fracture, especially in elderly women and in the hips, increase mortality. And also you want to change certain behaviors like smoking and alcohol. That's a big part of treating osteoporosis. So how we treat osteoporosis? There are some preventive measures, some non-pharmacological measures, and we have the drugs we use. We'll see in the next few slides. So what is non-pharmacological? It's prevention. Number one is exercise. That's your best friend. Everybody can do certain exercise. We stress it has to be a weight-bearing exercise. You have to put pressure on the bone for those osteoblasts we talked about to start building again. I mean, I talked to the patient about the bones being like the muscles. If you're building muscles and your muscles getting bigger, likely your bone are going bigger too, except you can't see them on the mirror when you exercise. So the bone go up and get bigger with the exercise, and it has to be weight-bearing exercise. And that will prevent fractures. The other benefit of exercise, if you're stronger and you're more fit, then you'll know you'll fall less. That's the biggest risk of fracture for people with high risk for falls. And then you have a bigger muscle mass to protect you too. So there's so many benefits of exercise, and we spend a lot of time discussing exercise regimen with the patients with osteoporosis. Fall precaution, like we said, beyond exercise, especially for the elderly population, we talk about their environment at their home, at night. Keeping in night light is crucial so they don't trip on anything. Keeping throwaway rugs away, the wires, their shoes, their slippers. I mean, silly things can make you trip when you're elderly or frail, or you have other osteoarthritic conditions. If you cannot walk, if you're dizzy or on blood pressure medications, we ask them to get up, sit down in bed, make sure you're not dizzy before you go to the bathroom, because that's one of the most common reasons for hip fracture is falling in your own house, tripping on something, or because you got dizzy. So fall precautions, crucial. And there's the others, like we said also now, stopping smoking and reducing your alcohol intake is one of the non-pharmacological therapies we use for osteoporosis. What else we use? Calcium, vitamin D supplementations are also part of the discussion. In general, the recommendations are for calcium between 1,000 and 1,200 milligrams a day. Better from your diet, hopefully a little bit more on that in the next talk or two. So better from the diet, and that's something we discussed. So if you have a calcium-rich diet, we usually tend not to give you too much supplements. So these days where you have to take these 500 milligrams of calcium 3 times a day regardless, they are gone. So we sit down, we talk about diet, what you eat, what's your preferences, and we make certain calculations, and we tell them, okay, you can take 1 extra calcium or 2 or none. So more is not better. Actually, there's one study that suggests for patients with high calcium intake in their diet, and we come and add these 2-3 calcium a day, could be at high risk of cardiovascular events or strokes. So more is not better here. You have to do your math right. So most, here in America, most people get their calcium supplement from dairy product and from their diet. And that's an easy discussion to start. I mean, how many glasses of milk or how much cereal you eat in the morning and what's your yogurt intake, frozen yogurt, cheese, and others. And that's how we start. There are other food that are rich in calcium, hopefully more on that later today. And this is a table we use where to see what's your diet habit like and to try to estimate how much you're taking throughout the day and how much you need, how much you're deficient in your diet to supplement with your supplements. These are the recommendations, like we said. If you are a man or a woman over 50, I think here it says 1,200. And in general, it's 1,000 to 1,200. You're never going to be 100% accurate, you know, because you cannot really estimate how much you're taking. But that's the ballpark. So these extra supplement, again, like 1,500 a day from pills, plus whatever you eat, are not good for you. That's the bottom line here. The vitamin D. Now, vitamin D supplementation is crucial, especially for those deficient. For those non-deficient, the National Osteoporosis Foundation here in the US recommends 800 to 1,000 units. That's why we check vitamin D in the blood, because there are these supplements over the counter up to 2,000, sometimes 5,000 that patients take every day. And here too, more is not better. So if you're not deficient, all you need is 800 to 1,000 units a day of supplements. More is not better here either. Now, if you're deficient, it's a different story. Patients who are deficient, and we call a deficiency below 30 on the blood level, depending how low below 30 you are, we might go with these big dose, 50,000 once a week. And we do this for 10 to 12 weeks usually, and we repeat the test. If you're now above 30, we relax a little bit. We do it every other week or every month, or we go back to your 800 to 1,000, and we keep checking once a year. So again, patients who are deficient only get these huge dose of vitamin D to replace, put them at a place where they can maintain after that. The question of D2 versus D3, now that's also, we get this a lot in the clinic, D2 or D3, there is no enough data to say which one is better. How I do it is, if you're on one or the other and I don't see improvement, I switch you to the other one. And the difference is D2 is derived from plants, whereas D3 are from animal sources. So some patients with strict vegetarian diet can prefer the D2 here. And again, I switch depending on the levels. I don't prefer one over the others. And now we go to the topic of pharmacotherapy and what we use and what we don't use and the complication of those. So what's FDA approved for osteoporosis? We have the group we call bisphosphonate. And I'm sure you recognize many of these names here. Perhaps the most commonly used is Fosamax or alendronate. There's ibandronate, risedronate, and the IV form, which is zoledronic acid. Those bisphosphonate work by reducing bone resorption. So they suppress your osteoclast. If you remember that slide, there's osteoclast eating up on your bone. Those drugs come and suppress osteoclast. They do not make your bone increase the bone formation. They just stop the resorption and let the formation catch up. And that's the most commonly used drugs in the general population and for the primary biliary cholangitis patients. Other drugs available, we're using less and less. It's this calcitonin nasal spray. Actually, the past few years, we stopped using it at MD Anderson. There are some data that might increase your risk of cancer, and we're in cancer institution. We're using it less and less. It's never been on the top first or second choice anyway. Data is not that strong. But we can use it in certain specific conditions, like acute vertebral fracture with pain. There are some studies say not only it helps with your osteoporosis, it might reduce your pain level too, and during the acute phase of a vertebral fracture. There are the estrogen, of course. Now, estrogens are very good for your bones, except they're bad for other things. So that habit of having everybody on estrogen replacement just to prevent osteoporosis is out more than 10 years ago because in research for breast cancer, cardiovascular risk, and so on. So it's not part of the treatment we use for osteoporosis anymore. Unless you're on it for other reasons, then we say, yeah, good, that will help your bones. And we might not add another drug. The PTH, which is parathyroid hormone, or Forteo, is the only drug we have now that stimulates osteoblast. That's the only drug that causes bone formation. It does not suppress bone resorption. That causes bone formation. The pitfall here, yeah, we might see the best results with this drug, but one most common cause of osteoporosis is high resorptive state. So really where suppressing resorption is a better option. And two, this drug we can use only for 2 years, so we can build you up for 2 years. We see improvement. We kind of have to follow it with something to stop resorption, otherwise 2 years later you lose all the benefit. But that's one of the drugs we use and very potent ones. And perhaps the newest one we have is the denosumab or Prolia. These are injections under the skin, like an insulin shot you take twice a year. This drug has also been used more and more lately. It is also an anti-resorptive drug. It stops the bone resorption, stops your osteoclast. That's how it works. It's a little different than bisphosphonate in the mechanism of action and certain side effects. And we sit down and we discuss the pros and cons for each drug, but this is commonly used now for osteoporosis too, especially for those who cannot tolerate the bisphosphonate. So who do we treat? We have those drugs, FDA approved. We have a patient in the clinic. Now, if you have osteoporosis, by definition, again, below negative 2.5 or minus 2.5, you're an indication to treat. If you have osteopenia and high FRAX score, like we said, above 3 for hip fracture, above 20 for all fractures, you are an indication to treat. And then you ever had a fracture, a fragility fracture, on your hip, on your wrist, on your back, regardless on your Dexa Scan results, you are an indication to treat. Now, like everything else we do in medicine, when you start a drug, they have side effects. You have to weigh in, you have to balance risk and benefit. And perhaps this is the longest time I spend with my patients discussing risk and benefit. Like most patients are reading about those drugs. They are reading about the nasty side effects, although very rare. And that's the first question they give us. I mean, how about side effects? How about my jaws? How about my hips? Are they going to cause brittle bones? And that's the biggest part of the discussion now, because once we make the indication and we decide to start bisphosphonate or Prolia, most people will get scared from the side effects. So we're going to talk a little bit about that. So like everything else, we're balancing benefits and risks, and we want to see which one is going to weigh more. For the benefits here, again, remember, we talked about the importance of osteoporosis, the prevalence of osteoporosis, and the fracture it can cause, and the complications of osteoporosis, from mortality to disability, nursing home stays, severe pain. So we have reduction of the fracture at all sites, and reduction of the risk of other serious complications. That's what we're benefiting from treatment, and it's well established that treatment helps. The risk of running is the common side effects. Different drug has differently. The most common, perhaps, for bisphosphonate are the heartburns or esophagitis, and the way you take those drugs makes a difference. We tell them to take it with a big glass of water in an upright position, go walk or shower for half an hour, or stand up. It's gravity. I told them gravity. Make sure the spill go down, because it's a mechanical problem where it gets stuck in the upper esophagus and causes severe esophagitis. That's the most common side effects. The other one could be joint pain, and we deal with that as it happens. Now, but that's not what worries the patient. Most of the time, it is the very rare and serious side effects they read about, and that we're going to see now. So what are those very rare and serious side effects everybody's bringing to our clinics? One is a jaw osteonecrosis, or dead bone in the jaws. That's been linked to those drugs. There are case reports. There are links to these drugs. We know they can cause it. Now, these are very rare. Now, you see here, one, depending what you read, again, 1 in 10,000 patient year to 1 in 100,000 will develop this. It exists. It's not that common. Again, your risk of breaking, it's a real and very high risk if you have osteoporosis and certain conditions. So these are rare complications. Most of them happen after dental extraction. So the question is, I'm going for crown, I'm going for cleaning, is that okay? Is that okay? As long as you're not touching the bones, you're fine. So if a patient has a dental procedure, with a jaw surgery, with extractions or implants, we'll wait, tell them go finish your work and come back. Then we'll start. Again, although the risk is very low. It has to have a bone involvement procedures. Anything else that's not touching the bone, we're fine. Yes. And the most common procedure is dental extractions. And certain patients are at high risk, like cancer patients, prior radiation to the area, and so on. Most, I mean, it's a nasty complication. Most will heal without intervention. Very few will require surgery for this. And good oral hygiene, visiting with your dentist, we recommend that at least every 6 months with cleaning and making sure you not end up in a situation when you need to pull a tooth or nothing, or something like that that will complicate your treatment. That's how it looks like. It's exposed bone in your jaws after you pull a tooth. That's your jawbone here. It might take time to heal. Some get infected. Again, very rare. Patients on long-term bisphosphonate tends to have those complications more, and we're talking more than 5 to 6 years. Patients on the IV forms for different indication than osteoporosis tend to have more of these complications, especially cancer patients with bone metastases, where instead of taking the infusion once a year, like our osteoporotic patients do, they take it every 3 months for bone cancer. And those are the most patient linked to these complications. Nonetheless, it's a class, it's a medication class warning on the, it's a black box warning on the medication insert. The other one is what we call atypical femur fracture. So remember, we're treating you to prevent fractures, right? And the most common fractures in the osteoporosis are the neck of the hip, like I showed you. These are fractures that are happening below the neck of the hip in the middle of your femur. We call them atypical because that is not your typical fractures. Now, they are also very rare. Less than 1% of all femur fractures are atypical femur fractures. And 2, not all atypical femur fractures has been linked up, and there are some studies like this one, up more than 25%, if you want, of atypical femur fractures happen with patients who have never been exposed to bisphosphonates or these anti-resorptive medications. But it could be nasty. That's how it looks in the middle of the femur. So why we treat? Now, I just showed you very nasty 2 complications. Why we treat? Again, risk, you balance risk and benefit. Again, some stats here. For a woman above 72, if she has osteoporosis and left untreated, there's a 25% chance of having a hip fracture or major osteoporotic fractures. There's a, for the hip fracture is 25, I think major osteoporotic is 12.5. These are real numbers. 1/4 of these women, if left untreated, will have a hip fracture. And I just told you, that increases your mortality, that increases your nursing home stay, that increases your disability. 40% will never recover completely from the hip fracture, depending on how old they are. So compare that to the risk of having a fatal motor vehicle accident is 0.11%. The risk of dying from murder is 0.06%. Your osteonecrosis of his jaw is 0.01%, roughly, depending on what you read. So it's a low risk. Serious one, but compare that to the 25% if you left untreated certain patients. The atypical femur fracture is also on the low. That's an estimate of 0.5%, also increased risk. So definitely, that's what we think. If you're at high risk, you have osteoporosis in one of those high-risk populations, the benefit of treating with those drugs will outweigh your risks. And we really don't want to scare patients off from not taking those, but just by reading those. I mean, they're in the newspaper, there's online, they can Google those pictures, they get scared to death from these. So really, we need to guide the patients through. I mean, yes, it can happen, but the risk of leaving osteoporosis untreated is much more dangerous. So the balance is tipped off for high-risk patients with osteoporosis toward the benefit against these rare side effects. So how long now? There's been in the news. Recently, most experts are trying to limit the use of osteoporosis, especially because of these side effects. As we said, the risk of having those rare side effects increase with the longer you stay on these drugs. That's one. So we are mostly limited those drugs to 3 to 5 years now, and we monitor. And 2, not only from risk of side effects, we do not have enough evidence that treating you longer with these bisphosphonates most commonly it will benefit your bone because the bisphosphonate usually goes and stay in your bone, and they're there to stay there, and they leave your system very slowly. So treating you beyond these 5 years are not proven to be beneficial. And two, if we can reduce these nasty side effects by stopping early on, it's also beneficial. So these days, you rarely see these patients on 10 or 15 years on Fosamax anymore, unless there's an indication, and there could be one. So how long we treat? So I have a patient on bisphosphonate if we don't think they needed it to begin with, because some patients just mild osteopenia without risk factors, FRAX score below certain numbers. We stop the bisphosphonate, and okay, you don't need those drugs. That's how long it stops today. For low-risk patients, again, we talked about high risk and low risk depending on your history and your social habits. Low-risk patients, we tend to treat for 5 years and stop, and we give what we call drug holiday. And for high-risk patients, some go up to 10 years and stop, give a drug holiday, or a little bit earlier. Some do 7, some do 8, it's all over. And in between, you can use other of these FDA-approved drugs, but not the strong anti-resorptive, which are the bisphosphonate and the newer denosumab or Prolia injections. We don't use them in the drug holiday. And what happened in the drug holiday, we check, we bring you back once a year, we check your bone density. We have to justify to put you back on these drugs by evidence of bone loss. If you see you're getting worse again, then we say, okay, fine, now we have a reason to take that small risk and keep you on those drugs. So how do we monitor patients? Moving forward, there are blood work. We check their calcium, their vitamin D, their kidney function, depending what drug we put them on, like bisphosphonate. If you have abnormal kidney function, you should not be using them. There are all of these drugs, the anti-resorptive drug we use. You have to have normal calcium to use them because they can cause hypocalcemia, which is a severe complications for those who are deficient. That's why we make sure that vitamin D, which absorbs your calcium from your body, is at a certain level. And we monitor for side effects, the one we talked about. That's how we monitor the patient on these drugs. So in summary, osteoporosis is common. It's more so common in PBC population. It is still underdiagnosed and undertreated, and we have to all be aware it can cause some nasty side effects, including fractures, and that's what we worry about. That's why we want to treat. We need to identify high-risk patients, especially primary biliary cirrhosis or others on certain drugs or other diseases. We need to ensure adequate calcium and vitamin D supplementation, but adequate we mean do not over-treat or under-treat. It has to be the right amount. Promoting physical activity is key. It has several benefits: strengthening your muscles, less risk of falls, and building your bone at the same time. The high-risk patient, like we said, we need to start pharmacotherapy, knowing the risks and monitoring for risk in moving forward, but we need to treat them. We cannot leave them untreated. And the most common new drugs still used now are these bisphosphonate family. Is it IV or PO? Maybe we didn't mention that before, for patients with liver cirrhosis, and sometimes they have these varices. We tend to avoid the PO forms of the medication. We go straight to the IV